So greetings everyone once again and welcome to the 152nd session of the online Optom learning series OOLS. And for today's session we have with us Dr. Debarun Dutta. Dr. Dutta is a tenured lecturer at the Optometry School, College of Optometry, Health and Life Sciences at the Aston University in Birmingham, UK. He does academic teaching and has responsibilities for both didactic lectures as well as preclinical face-to-face teaching to optometry students. His main areas of focus are on medical biology and pathology, contact lenses, and optometric clinical practice. He is also involved in a lot of translational research in the areas of contact lenses, dry eye, ocular infections, and antimicrobial strategies, which includes supervisions of higher degree research students as well. He is also the council member for the BCLA. And today he is going to talk to us about a topic which I think he likes a lot. He was just telling me that this topic is something which he does a lot of research and would like to educate all eye care professionals about, which is the tear film biomarkers in dry eye diagnosis and management. So welcome Dr. Dutta onto our platform. And let me just leave the screen time to you.
Thanks, Fakhruddin. Thanks so much, and thanks everyone, and welcome. I'm very glad that to be in your channel, and we have been part of the OOLS lecture series. And so it's a good idea. Thanks, Fakhruddin. That it's a good idea to know my audience. And since most are optometry, of course, and some 1/3 are students, the rest are coming from are practicing in different forms and also teaching a few. So so today is one of my favorite topics. It is in tear film, and it's very close to me because my area, as I said, Fakhruddin, that contact lenses and ocular surface is the main area that we're working over a decade now, and including some of the infection works that I did before. So in overall, I think we're trying to drill down a little bit, knowing about tear film biomarkers and why these are important, and to an extent how they are available in the market to diagnose and management, but also kind of research which are probably in the future and which may help us to better diagnose, which will be followed by some of the evidence-based clinical management that we would like to look for. And when I actually Fakhruddin invited me for a talk like, and I was looking at your channel, so there are a lot very good informations available about our overall management. So I'll touch the management at the last a little bit and try not to repeat with the fantastic information already available, but it's just mostly focused on some of the better diagnosis of tear film and what we can do and could be doing in future. So little bit of disclosures that I don't have any conflict of interest for what I'm talking today, and also I get receive funding as some of the industry partners, but none of the interest actually applies for what I'm going to talk. And slide. Right, so this is Aston School, Aston Optometry School here, which is part of Health and Life Sciences, and I am here for the last 2.5 years now, and have been before with Brian Holland Mission Institute, Sydney, with and also School of Optometry, University of New South Wales, Sydney. So I worked there for 19 years and then moved here 2.5 years before. So it's kind of a mixed bag of Australasia and UK, Europe work. So at the moment, my research team, which I primarily supervise, I have few co-supervision students, but it's on the left, we have Ms. Rachel Casemore. She's an experienced optometrist here at Midlands, and I've been working here for more than decades. And this is what I'm going to talk today, and an acknowledgement that most of the work, the literature and management that I'm going to talk today is essentially her work when she was doing literature review as part of her PhD, which she has nicely summarized everything. It's really helpful. So the next is David. He recently joined, and he's also going to work on a variety of dry eye management techniques and try to guess or guesstimate first, and then kind of confirm in the study that which are probably the best or may not be the best way to look at that how we treat our dry eye disease. On the right, we have Srikant Tumpati, and he's looking at, he's a Marie Curie fellow with us for the last more than a year. And he's looking at a little bit different than dry eye, but it's mostly eye infection and contact lenses, and how you can reduce eye infection, contact lens related particularly, reduce contamination of contact lenses and lens cases by novel technology with UVC. And he has been, he had a poster, a presentation in BCLA. He had a talk in Academy Optometry, but he couldn't travel. So hopefully you will be able to present more of this research in the future. So this is overall, it's my work. I do collaborate with many around here and across the globe. We all have seen what is dry eye. I thought a couple of slides first, just a very brief reintroduction of our definitions. This is been formulated like 4 or 5 years before now. And here I'd like to mention that it's a multifactorial disease in ocular surface, which is characterized by loss of homeostasis, which means the imbalance in the tear film, and which is at the same simultaneously is working with the tear film instability. Of course, anything is different will make it unstable. Hyperosmolarity. So we know osmolarity is the number of solutes in a soluble. So there's a more number of solutes in a solution, which makes more thicker. And it's ocular surface inflammation and damage. Of course, this is where most of the mechanism goes on. And if it's a chronic, it's a long term, or it's a subclinical, depending on the terminology we use. So it's something which may not be able to see very easily, but it's going on underline and under the carpet, and it's over a period of time, it causes inflammation and a damage, which eventually come as a mild, moderate, or severe dry eye. And in contact lenses, and this area also has quite a bit of applications, because we know contact lens wear can help with the development of dry eye, and those patients are with preclinical or existing dry eye are not very comfortable often with wearing contact lens. So this is a fine balance for us. Yeah, and it also has neurosensory abnormalities, which does play etiological roles, which means it does lead to more and more dry eye and problems. So I know the 1/3 of here are optometry students, and when I was studying optometry like 15 years before, so probably very old now, we didn't have such a good definition, and it was more of a generic definition. So it's great that when you are still an optometry student and getting this, so having these keywords, keeping in your mind when you are studying and also seeing patients is very important, that it could be many of them. So it's a puzzle of always, and it's only me, dozens of experts around the world, and many of the lecturers at this channel in OOLS has really rightly mentioned that this is a quite multifactorial, multi-etiological disease, and thinking about one single path of management treatment may not be accurate. But what we need to look at is what the best way in a clinic we can work on and see the best out of it. So then instead of spending more time and trying to describe dry eye disease, I believe you have some understanding with the information there before. So I'll directly jump with a few of the key factors here. So like signs and symptoms in dry eye disease often does not correlate. And that happens all the time, particularly when it's a preclinical or it's a mild form of dry eye. The patient doesn't have any symptoms. You look at the eye, there's almost 5 or 6 out of the key signs you can see, but patient is still not fine. It's a multifactorial disease, as I said, with lots of a variety of etiology, and they overlap. And many of them, they go hands in hand, but not necessarily they'll start at the same time and have a severity the same time will have a similar severity, and they progress differently. It is hard to treat the disease, and it's much easier to misfire because you need to understand which directions it's going. And thanks to a lot of research work and consensus reports, workshops, it's still better, but still we need more information on this. Now, once a patient has gone to severe dry eye, which I'm particularly moving and directing toward Maven gland disease, it's not easy to actually have fully come back to fully healthy normal eye, because they might have dropped a lot of glands, may or may not secreting, the lipids are not great enough, or there's aqueous deficiency for different reasons. If it's not having enough flow of aqueous, it is hard to cure. So it is important to actually stop the progressions before it goes to a severity level. And that's why I always stress that we talk about pre-diabetic or pre-hypertensive patients who needs their changing lifestyle, who needs changing of their food habits. And this is something that we are trying to do it, and we should be doing it more and more in a dry eye, because it's if you can get them before they're moving even mild and moderate form, they will have much better prognosis and outcome at the end. And it's an example that in our cohort that we are looking at our current first and second year students. And as Fakhruddin mentioned, that I do teach contact lens and I lead the module here. And we're seeing more and more even young adults, less optometry students we have, those are between 18 to 21, having a fair bit of dry eye. And it comes back because we do the practice on each other. And during that time, it comes so that they have a fair bit of dry eye going on. And even inserting lens is very sensitive eyes, and if you do work up properly, it just lots of dry eye. And that's perhaps pandemic and increased screen use as some of them could be, and very likely to some of the predisposing factor for this. So it is very important for us and the next generation of optometrists, and currently, that we need to really screen very well. We not only look at severe, moderate, and mild form, but also those who are pre-dry eye with very mild form of sign and symptoms. And that's why this today's lecture talk starts, that how we can look and look at them before, or diagnose before, know before, when there's almost no sign and symptoms have appeared, but they are actually underlying mechanisms have started. So currently, dry eye disease treatment is largely based on alleviation symptoms. Often it could be a simple form of eye drops, and the eye drops stay for only a few minutes, and maximum half an hour, etc. And then when it goes back, the patients the same signs and symptoms will come back. So it's just a kind of masking than actually treating the main disease. And when you look at patients' perceptions on this, a survey in ophthalmologist perceptions and treatment of patients with a moderate to severe dry eye, which is kind of higher end, they found that the majority of participants felt treatment options lacked effectiveness. So the treatment doesn't really fix the problem, or there's a gap exists between artificial tears and effective treatments. I mean, we have our arsenal of various treatment, but they are just not adequate enough, or we need more smooth transitions and better treatment, perhaps. So then it takes turn towards trying to understand and diagnose dry eye. If we know there's a dry eye, and if you can kind of quantify or qualitatively or quantitatively, then we perhaps can start treatment or monitor the patient. So what are biomarkers? And the biomarkers are quite well researched in other part of the healthcare and medical systems. It's a defined characteristics that is measured as an indicator of normal biological process. Could be pathogenic processes, a response to an exposure to interventions, including therapeutic interventions. They may also be molecular, histological, radiographic, psychological characteristics. Now, it's not a measure of how a patient feels, functions, or survives. As an example, how a patient feels for us could be a questionnaire, which is grading their symptoms. So biomarkers are generally not, that could be some of them if they're really good at it. But how the function then survives, essentially, it's a key ingredient and assessment of only a few tests, which will tell us at a scale of 1 to 10 how much it has progressed, even if there's any progression. Yeah. So an ideal biomarker, if you want to diagnose dry eye, it should be easy, minimum invasive. It should allow accurate diagnosis, which means high sensitivity and specificity. Just quickly, sensitivity and specificity. Sensitivity is a test which can accurately determine which is it is yes or no. And specificity, it can tell us which is a treatment correct or not, the diagnosis of correct or not. And it will facilitate classifications of this disease in question. It could be, and it should be able to predict the outcome and respond to any treatment. So it should be quite accurate. It should be easy to administer in an easy for optometry clinic. And also, if we know what is going on and we can quantify it, perhaps we can try to manage it with the existing treatment options available for us. Now, there are quite a few established examples, and I gave just two quite common ones. One is thyroid stimulating hormone. It's a free thyroxine for various thyroid diseases. Many of you might know it. This one, I'm sure many of you know the second one, which is plasma glucose concentration, which is hemoglobin A1C, and it's for type 2 diabetes. And often we go to the normal blood test, and this is one of the components which has been tested. And it not only checks the sugar level instantly, which is random sugar level, but what it does is actually gives a doctor an idea of how the sugar levels in the last 2 months, which means even if you have been there for dieting for the last 5 days, trying to reduce the blood sugar before going blood test done, it's not going to mask it. That's just because before that you might have a high blood sugar. So these are the quite established biomarkers, and they're really good at determining if there's something going on or something will be going on in future, and its patient is going drifting towards a certain type of disease. And we need something like this in dry eye. And what I'm saying is particularly before a patient has gone on to have a moderate to severe dry eye signs and symptoms. So as I said, the early diagnosis and intervention is a key. And we are looking at quite a multifactorial disease. It has lots of underlying pathology and etiology. And there are various treatment management options available, depends on what type of dry eye it is. And to an extent, we need also more treatment options if someone has progressed to severe to moderate to severe dry eye. As I said, hemoglobin A1C used as a surrogate for diabetes control. So if diabetes is being controlled, even with the medications, then doctors will continue to monitor it and how it's going on. But we don't have anything like dry eye disease. And ideally, we should have a simple test to check yes and no, which is hard to say, but at least can quantify and kind of get assessment of quantitative and qualitative assessment that how much dry eye is there, or if it's what's in a 1 to 10 scale, why it is. And if it is, that is quantified. So let's look at some of the simple ones first. And we may or may not always call them as a biomarkers, but then if it's any test which telling us and quantifying, telling us that as a stage of dry eye and assessments, perhaps it will work well. Imaging and questionnaires does very well because questionnaires are quite established, quite validated, and quite presentation publications we have now. OSD does very well. There are a few others like Speed, DEQ5, all have their own advantages and disadvantages, but they do a fair bit of good work in terms of understanding how the patient really feels. But remember, that doesn't really say anything about what going on underlying problems. The patient is not feeling it, or they might still have signs in eye which is not reflecting in symptoms. Imaging, non-invasive breakup time, TR meniscus height, bulbar redness. These are other really good criteria, clinical criteria to look at. And at the moment, it's quite standard in a dry eye clinic to administer a questionnaire, non-invasive breakup time, TR meniscus height, redness together. So all together, how many ticks we have. So it's more of a confirmation of dry eye. Dendritic cell density has been shown. These are following confocal microscopy that these are antigen-presenting cells, and it does really well with inflammation. So if someone is having symptoms but no signs, we can still perform confocal microscopy and see if we find dendritic cells. Now remember, it will only tell the inflammations, and it may not be because of dry eye, maybe something else, but it still tell you that there are inflammation going on in the eye, in the cornea. Now, for the other biomarkers, if we can look at the tear lipid layer. There are various instruments available, and time permits. I'm not going in detail today for this lecture. At least there are instruments like LipidView, which can measure the lipid layer thickness and does really well. There are various qualitative assessments to how the lipid layer is. It's a meshwork, it's an open meshwork, or it's a Goulion lipid layer tear film assessment. So you can do. Now we have tear finding, and at bottom right we can see. Can you say play the video from before? It's one of my students back in Sydney who actually did it. So it's a with a capillary tube or any other method which you can have a little bit tear, and just place on a glass in a glass cover slip, and then let it dry based on the temperature and dryness. The tear will produce finding patterns, as you can see bottom right video. And based on the pattern, we can, and it does really well with the severity of dry eye signs and symptoms. It's pretty easy to do in a clinic. Just be careful when you're taking the collecting tear. Microcapillary tubes are most commonly used, and they did very well. And under the microscope, you can see they're nicely creating pattern. It's amazing. And the more pattern, more fern are there, it is better, which means it's not so much of dry eye. But when the severe dry eye cases, the pattern will not have, or in fact, sometimes there's no pattern at all, which is telling us it's something not right. It's probably abnormal. Extension of viscosity in the tears, we can do acoustically driven microfluidic extension rheometry. This is some of the ones which not done a lot, but we can still look at the viscosity of the tears, which various means, but and can look at it. In bottom left, we have here various assessments of tear lipids. Now, tear osmolarity, I'm sure you have done it or have heard about it or read about it. It's been used for last 11, 12 years now. And we know the tear film, there's loss of homeostasis due to the hyperosmolarity, and tear osmolarity assessments does very well. FDA approved this in 2009. It's now commercially available as point of care. Lab on chip test. It can be a bit expensive in some areas in the world, but it does test very well. It does tell us that what's if it is hyperosmolarity or not. The cutoff threshold is greater than 308 milliosmol per liter and should be used for the most sensitive differentiation. It does pretty well. And if there's difference in the right and left eye, greater than 8, I think, milliosmol, and then also you should suspect something going wrong. So what is hyperosmolarity is essentially due to increased electrolytes concentration. So because of dry eye, there's imbalance. That's a loss of homeostasis happens in tear, and sodium, potassium, calcium, and extra ions and salts are much higher concentration in tear than it should be. And that's why it actually determined by it does work very well. It's quite sensitive to mild and moderate cases. You can classify them. And that's qualitative because it does give numbers. It is a good qualitative assessment. However, as you know, dry eye disease is quite multifactorial and a lot of things overlap each other. It may not always correlate with clinical signs. As we dig deeper with some of the other biomarkers, next is MMP9, or matrix metallopeptidase 9, and it has been known for more than a decade now that it does there's upregulation, which means increased concentration when there's a dry eye happens, and it is regularly seen in research. And it's a class of enzyme. And most importantly, if it's increased in a tear, what it does, it degrades the extracellular matrix. So when it starts to degrade, it starts to degrade everything in there and intraocular surface. It becomes toxic more more of a TFM. Always increasing dry eye diseases. We do have commercial point of care device, which our clinic here use regularly, particularly in research studies, and it's from inflammatory dry, depending on the suppliers in the world, which part of the world you are. And patients without dry eye disease has an average of 8 nanogram per ml. So this is a quantification done by researchers. It's on 8 nanogram. And the detection threshold for the kit used, which is around 30 to 40 nanogram per ml. And it does have very good sensitivity and specificity. So I'm not saying this alone or single-handedly can differentiate a patients with and without dry eye disease, but it can really do a very good job when it's been used as a series or battery of tests together. It's very sensitive. It does tell you if it's a dry eye or not, but I'll come in subsequent slides. It will also tell us that what type of dry eye it is, because you need to really differentiate between aqueous deficiency dry eye and evaporative dry eye. There could be some patients which are overlapping, but their treatment will be very different. So that's why it is important. So this slide shows us the MMP9, and you have 1, 2, 3, 4, 5 MMP9 chips and its tool here. And the left-hand side, so let's have a look at the top right here. So this is it's like a pregnancy test, or we're doing lateral flow test for COVID nowadays, which is rapid antigen test, what do you call them? Essentially, you put a drop of tear there. Sorry, you just go back down slide. So that's a kit, and there's a small surface, which I think is a blotting paper type thing, which will come with the kit there, and you just take the lower lid, and ask the patient to look up, of course, always from away from cornea. Ask the patient to look up, just have the little bit evert in the lower lid, preferably in the temporal side, and have a gentle touch with the tear there, and a hold on for a few seconds as the instructions given there, and then put it back to the kit where it is, and it gives you line. So of course, one line, first top one, it shows is control, which means if it is the test is working, and the second line, if it appears with a red line, which means the MMP9 is positive, which means it is above at least, as you see here, around 30 to 40 nanogram. Now, as the company mentions, the darker the bands are, which means there's more and more MMP9. And that's really helpful to actually see if it's a lot of dry eye or it's a slight dry eye. And you can try to kind of assess how severe it is. So this is exactly what I'm showing you top right here. It's an MMP9 kit, and it's a absorbent pad, and then it goes to the small box here. The couple of lines should appear if it's MMP9 positive. Now we have 5 kits here, and it has various different type of results. In the left-hand side, we see it's a MMP9 negative, and when actually tested with the 8 nanogram per ml, which looks like it's a normal healthy tear, and we see only one mark here, which is the black line, and there's no red line there. Now in the second kit from the left, we see, of course, test is working. There's a black line at the top, but there's a red line. It's a faint red line there, which means it's mild positive, and it was traced with 34 nanogram per ml. It started to become a little bit positive. As the MMP9 concentration increased, we can see from the 3rd to 4th and then 5th, the red lines started to become more and more dark, and at the very high concentrations, 381 is really high, the patient may have moderate to severe dry eye. It just tells us that it is MMP9 positive, which means definitely you should suspect for strong suspicion for dry eye disease. So it's one of the biomarkers as available, and if it's positive, I think you should start thinking about a treatment of dry eye. If the patient is still not symptomatic, look for symptoms with questionnaire, or look for signs, what is happening there, and if you can pick up anything. Still, if it's still not, which is Generally not. If you still find it, you should start some sort of alterations in patient's lifestyle, better food habits, supplements, etc. But then you have to really correlate this with your signs and symptoms. So the helpful here is decide between medications and punctum plugs. Now, if someone having a lot of tear, not very symptomatic, but it's MMP9 positive, I will not go for punctum plugs because there's a lot of tear there, which means it's not aqueous deficient. It's perhaps evaporative type because there's a lot of tear there. And I will not go punctum plug because essentially then you are allowing the cornea continue to bathe in a toxic tear, which is a lot of MMP9, and allow more and more degradation of extracellular matrix. It's like taking bath in a dirty water. So you want that to flush off. But then you really want to start some medications or alterations of medication treatments, managements, should start on that. Now, if someone is MMP9 negative and have symptoms and doesn't have a lot of aqueous in the eye, so there's not much of tear in the eye, which you suspect for at least aqueous deficiency, if not both aqueous deficiency and evaporative type. And you do MMP9, which means the underlying mechanisms of MMP9 has not started, perhaps suspect for one of aqueous deficiency type. And then punctum plug is a good idea because the MMP9 is not very high, and you still can allow the tear to stay in the cornea more and then reduce signs and symptoms. Now, let's move on to a couple of other tests that could be done in a clinic. The first one is lactoferrin. It's a globular glycoprotein. Also has an antimicrobial and healing activity. It's mostly anti-inflammatory functions, which means unlike MMP9, where dry eye is more, the concentration does increase. Lactoferrin concentration will decrease, and it's essentially a marker of how much tear is produced there. And it has an anti-inflammatory functions. It decreases dry eye disease, assessment of aqueous production. Now, when I look at the research papers looked at, and they looked at as around 2 milligram per ml in a controlled objects. When I think it's a typo here. When it's looking at dry eye disease, it's actually reduced to 0.69, which is around 0.7. It should be dry eye patients. Now, it's a very good idea to do this because you can differentiate between dry eye due to reduced tear secretion and dry eye caused by rapid tear evaporations. And of course, assessment of aqueous and tear secretion could be done very other simple tests like Schirmer's with another anesthesia, depends what your clinical setting is, and few other like phenol red thread tests can tell us the total volume of tear film. But what lactoferrin does really is that it doesn't have any other bias of extra stimulation going in the eye when you're trying to insert Schirmer or Schirmer strip or another thread in the eye. So what will happen is it gets quite a true and correct test as a normal volume of secretions, what's happening, underlying mechanisms. So that's quite easy and very important. So this is the TScan 300 T analyzer available, and it's a quantitative test. It does tell you the level of severity. It doesn't have bias or extra stimulation, which can be caused by Schirmer strip, etc. Now, below 0.9 milligram per ml is indicative of tear deficient dry eye. That's been mentioned in the various research papers that have been looked at before. And it's have very good sensitivity and specificity. Specificity is kind of okay. And this is the kit we have in the bottom right. It does come with the tear collection small plastic tube, and it's a plunger, and then you can put a drop. It does gives a number, and by the number, looking at it, we can quantify if the tear secretion is normal or not. And the normal tear secretions, as you know, lactoferrin will be high, and it's a reduced tear secretion will drop. There's one catch here for both lactoferrin and MMP9, is a tear volume. Particularly for MMP9, if the tear volume is very high, for some reason, it can still give you a little bit of false positive results because it's been exposed to a lot of tears. It's accumulated more MMP9 than a second test, which has not been exposed to a lot of tears. So just need to be mindful when performing these tests. IgE, immunoglobulin E, is essentially an allergy biomarker. I just kept just to let you know this is also similar as a lactoferrin kit available, and that could be tested. So if someone having allergic reactions, not actually inflammatory because of dry eye, etc., could be looked at it and could be measured with the fluid, and also the fluid increases the severity of inflammations, just to rule out if someone having allergic reactions. Now, this slide is important in terms of determining two things: what kind of dry eye the patient has if it's not a contact lens wearer, and if the patient is interested or wearing contact lenses, what are the possible risks? Will the patient be a good contact lens wearer, or will the patient be a good to go ahead for treatment of evaporative type and not aqueous deficiency type? So let's look at in the top left, and it's in dry eye and allergy, which are actually buckle them together. With this nice article, they said the TR chemistry is normal lactoferrin, which means normal aqueous secretion, and normal IgE, which means there's no allergy going on, and if patients still have symptoms, it's very likely to be evaporative type because aqueous secretion is okay, determined by lactoferrin. It is a normal lactoferrin, so the plenty of tear in the eye, high IgE, definitely allergy happening, and it's and if it's maybe evaporative type, but then definitely there's allergy. Now it's a low lactoferrin, which means tear volumes are low, and normal IgE, then it's a aqueous deficient dry eye because IgE is saying it's not allergy at least, and lactoferrin telling us it's suppressed lacrimal functions, so it's definitely a aqueous deficient type, and you might need to still rule out evaporative dry eye type with a few other clinical tests, and then go ahead with punctum plug. It's probably a good idea. Low lactoferrin and high IgE, which means tear secretions are low, inflammatory and allergic reactions are very high. It's a definitely aqueous deficient, but also an ocular allergy. Yeah. So if you go next part, which is particularly looking at contact lens patients, could be a neophyte, which is new to contact lens wear, or existing contact lens wear, and you can try to foresee the risk of the patient dropping out of contact lens wear, because despite how good the contact lens it is of material and brand and parameters, the patient might drop out because it's too sensitive, because we have dry eye. So if the normal lactoferrin and IgE, which means normal lactoferrin means normal tear secretion and no allergy present, it's a good candidate for contact lens or continue to wear contact lens wear. If it's a low lactoferrin, which means aqueous deficient, which means it could be a hypoxia, it could be bacterial conjunctivitis, or contact lens dehydration. It could be various different reasons. And some of the indications also include contact lens desensitizations, which means it doesn't sensitize a lot because the tear is much low. High lactoferrin, a lot of elevated tear proteins and a lot of tear secretion happenings. Nowadays, we don't see much as excess tear deposits because previously we used to have a fair bit of patients. And also, I think some part of the world, I think Malaysia, India, and South Asia, we have still a bulk of patients do use contact lens on daily wear basis. And you have to really look for these patients if they can have contact lens deposits because it's a more tear and it's more lactoferrin. They're likely to deposit, and they like silicon hydrogen materials. And if it's a high IgE, which means definitely allergic reaction happening, for contact lenses, it can be GPC, which is papillary conjunctivitis, and also inflammation going on, giant papillary conjunctivitis. So it's a big cobblestone appearance can happen. So that's allergic reaction to contact lens wear. So I think this table is telling us that which direction we go based on just lactoferrin and IgE tests. Now, what I move to the next part is some of the tests which are not yet available in the market, but this research is continuing, and we should have some understanding that which directions it might go. The first is lysozyme, which is another antibacterial enzyme. It's readily present in our eyes. generally reduced in both aqueous deficient and evaporative type. Not a very good sensitive biomarkers has been seen before. It just vary between different studies. So we probably not pick up lysozyme anywhere soon in the near future. The next is Lipocalin. Again, it's a binding and release of lipids and regulation of tear viscosity and anti-inflammatory activity is very good for our eye. Reduced concentrations in Meibomian gland dysfunctions and other type of dry eye disease, which means we need more and more Lipocalin to actually be in the tear because it has anti-inflammatory activity. It correlates negatively with fluorescent staining. Of course, it's more fluorescent staining, which probably means more dry eye, and if it's more dry eye, Lipocalin concentration will drop. But it does actually positively tear film pickup time. I mean, it's a quite not a consistent results in this. The deficiency may be a predisposing factor, and it's a development for and a factor for Meibomian gland disease. The sensitivity and specificity for this particular protein is still inconclusive. So it's probably not the best or the top candidate we're looking at for biomarker. Now you have a few series of other small molecules. First is secretory immunoglobulin A. This is one of the major antibody present in our tear film. We know antibodies are good as we're having vaccines all over the world. We're trying to have more and more antibodies that can fight with coronavirus. And similarly, it's one antibody which is present in tear film, has various other tasks. Its concentration increased dramatically during prolonged eye closure, like overnight sleeping. We're not sure if it's responsible for subclinical inflammations, maybe just inconclusive. And it's reduced in tear fluid for dry eye patients. It doesn't really correlate very well. It's not very consistent results in terms of making it a good candidate for now, at least. Now we have one multifunctional cytokine. Now cytokines, I will come next slide. You might have heard this word before, but I think as optometry students and if you're practicing, it's a good idea to understand or know the name of cytokine if you're in our contact lens and ocular surface work. The cytokines are essentially messengers. They're very small protein, and they don't do a lot of work by themselves like Lactoferrin and Lysozyme does, but they are messengers. So they message to relevant cells and tell them secrete XYZ. So if we can pick up these cytokines really early, so before the messenger has gone to the cells and started to upregulate MMP9, etc., we can still diagnose the pre-dry eye patients who are eventually in the next few years, without any intervention, may develop dry eye. And that's why cytokines are, and understanding cytokines are very important. Lots of research going on in these directions. Now, transforming growth factor beta 1 is one of them. It helps suppress inflammation, is good for us. Increased concentration in dry eye, which means it tried to reduce the concentration, reduce the dry eye, but probably continue to fail. But we need to understand more about this one. We have a candidate which is called SPLA211A, which is secretory phospholipase A2. We know the concentration increase in dry eye, but then it still needs more assessment in our understanding. Now, cytokines and chemokines, as I was saying in last slide, as an optometrist, and as I said, our young adults here, our cohort is having more and more dry eye. I think in the next 5-10 years, we'll see more and more patients are having dry eye. So if our young adults are still having dry eye, imagine our population globally are aging. And the more aging happens, we know it's correlates very, very well with dry eye disease. So that we're going to have more and more dry eye patients coming in. Cytokines are essential in regulations and maintenance inflammatory processes, and they are signaling molecules. As I said, they're messengers. If we can tap into them and can see their upregulates or downregulates and have some kind of understanding before their effect has gone to the cells and started having inflammatory reaction, which is translating to signs and symptoms, we are kind of step ahead, and we can start our management way before they go out of our hand. And they are, I think, just the names for this channel is good now for to know is tumor necrosis factor alpha, interleukin 6, interleukin number 17A, interleukin number 8, and interferon gamma. They all are raised in dry eye disease, and they are early signals. So if you can pick up the early signals before the incident has happened, we are better off to actually managing dry eye disease. Now, these tiny molecules are hard to monitor, and that's why different research paper has looked at very different methods. Different research groups have looked at it with inadequate study design, can be quite expensive in the lab to run, and different instruments are used. So at the moment, there's not a very clear understanding of overall what happens. But overall, we know each of these molecules are heavily influenced during dry eye. They influence dry eye very well, and we need to monitor them. So I think the last slide I want to spend a few minutes is just very quick management of dry eye. So in the previous slides, we tried to touch on what's biomarkers, how we can diagnose established dry eye, which has been covered before, and I did cover some of them today, which is signs and symptoms, but also some sort of test, easy to do in clinic, tell us that, okay, these directions we're going, this direction should not go. If we go this direction, what the management should be. So next slide, it's going to talk about some of the evidence-based dry eye management, which is essentially developed in consultation with me, Rachel, we have a research fellow here, Sonia, and also by Professor James Hobson. So at first, we have patients present with dryness complaint. And then what you should do is the detailed history and look at the risk factors. And look at the risk factors if anything is modifiable. And that's the first thing we should do. Now, we know very well BCLA Clear report, the global consciousness report we have, it does talk about also looking at the dry eye risk factors even before prescribing contact lenses. So when you have detailed history and risk factors, we should be able to differentiate diagnosis between aqueous deficiency and evaporative dry, or maybe mixed, and try to quantify the symptoms. Is it moderate, severe, or mild, or maybe it's just a pre-dry patient. So if I go next, and then we go ahead with some of the tests, which is non-nuclear breakup time, staining, and osmolarity. Now, if it's not, then we can just see pain referral, because if they're not correlating well, then we should actually know better with anesthetics, and we should actually go for pain referral. That goes in different directions, and often we refer to ophthalmologists for this. So now, if it's yes, and then we go for subtype, and the subtype is aqueous deficient or evaporative dry. So TR meniscus height, mammography, interferometry, which is assessment of the lipid layer thickness, and meibomian gland expression will tell us which direction is going. Is meibomian gland dysfunctions and what type? So if it's aqueous deficient, which means TR meniscus height is low, but their meibomian glands, etc., are doing pretty well, then artificial tear is a very good idea to start. More viscous, it stays in eye more longer, and of course non-preserved, because they will not cause essential more inflammation in the eye. And currently we know that we should wait for a month and see if the treatment is working. We should not wait for many months and ask the patients to come after 6 months. If it's not working for a month and patient is still complaining of more of this, we should go ahead with punctum plugs, because we need to preserve the tear. The tear is good, and tear is not toxic, hopefully, and we can look at them. And what are the options we have? We have scleral lens, we have serum and amnions, and we have secretagogues. It depends on where you practice, which one is readily available, or perhaps you can actually co-manage with someone who does prescribe and manage this type of patients. Now, when I go for other way, which if we think it's evaporative, which means TR meniscus height is okay, but then as a meibomian glands dysfunctions and lipid layer is compromised, then we try to look at the treatment such as artificial tear. And of course, it's a more of lipid based, because we want to complement the lipid, so tear is more stable. It's a liposomal non-preserved spray drops. We have warm compress to help the more meibum, the lipid, to come out and protect the tear. and lead hygiene, blepharitis, and demodex, etc., which is more of a management of the leads, which we quite often do it as a first-hand treatment and management. Now, again, we know with a recent study that we should wait for a month and see what happened. We should not wait for very long and continue to have symptoms for the patient. If it's still not working, we need to look at in-office lead management and see how the patient is doing lead hygiene, blepharitis, or maybe ask the patients to come regularly to have lead cleaning and see if the signs and symptoms should be better. The other options are going for IPL, depends on which part of the world you practice, and over next 2 to 3 months, and IPL does pretty well job in terms of keeping the symptoms and sign low for a while. And if it's still not working, or it's partially working, it next need to go for anti-inflammatory antibiotics, depends what type of disease and its way progressing, so I need to co-manage. I think this is overall management of dry eye and currently evidence we have. At the top also we have advised disease and environment, diet. These are modifications you do at the top when you take history and risk factors. You have subtype, what type of disease it is, a dry eye, and advise the disease, environment, and diet. So with this, where our biomarker sits, and our biomarker sits right at the center, where actually trying to differentiate aqueous deficient or evaporative type, but also biomarkers can sit easily at the detailed history, risk factors, and continue to do diagnose. And perhaps at this point, if the patient is pre-dry eye patient, you may be able to act, or you should be able to actually foresee if the patient will land up to having dry eye in future. And that you start to have the advice, disease, environment, and diet maintained and to slow or lag or delay the progression. I think that's all for me today. So it could be mixed, and when I say mixed, you need to really put them together with artificial tears, viscous and liposomal sprays. But it depends, again, the biomarkers and testings should be able to help you and quantify what directions it's going. With this, I think, thank you so much for everyone for your patience, and thanks Fakhruddin and OOLS for inviting me here. And it was glad to talk to all of you. I'm happy to take any question if you have.
All right. So thank you so much, Dr. Dutta. I really like the last slide, where you put up all together. That's really important, because as clinicians, we need to know what should we do next. We have all these biomarkers, and, that's really important. So thank you so much for, summing it up all together. So the first question, just to begin with, is you did talk about so many biomarkers and the ways to detect the IgE, the IgE, and immunoglobulins and cytokines and all of that. Which one do you think is the most important and the most prevalent? So if I want to pick one test, which one do you think would be the to-go test in a clinical practice?
I think that's what I'm saying. There's one of you, as a dry eye is quite multifactorial and could be for various different reasons. It's hard to say is one single one to pick in all the biomarkers. I think it's the best way to do it is a battery of tests, as you are doing is signs and symptoms with questionnaires and tear film assessment, etc. I think the first go-to test will be, and it's mostly available, is MMP9 test. And MMP9 test will tell us if this underlying inflammation going on. If it's high, which means even the patient may not have signs and symptoms, but if it's MMP9 positive, which means you need to really start thinking about modifications and managements based on the severity of the signs and symptoms. And Lactoferrin was next one, which is, I'm not sure if many have been doing it. Some of the clinicians are doing in Europe and United States, I think, and they are using it as a support, saying it's a fair bit of aqueous secretion happening. And also they have applications for ophthalmologists, those who are doing refractive surgery.
Mm-hmm. All right, great. So yeah, it's something which is hard to answer, right? Because of the multifactorial in nature. So you don't have a direct answer to it. I do understand that. the one question which has popped up is anything you would like to add on the autologous serum? Again, this is not directly related, but I thought I'll just take it up.
Now, autologous serum is a serum which is autologous, as it says the word autologous, which means it's with blood drawn from the patient and which we're treating, and from there the serum is extracted, and this serum is a fantastic healer because they have all the ingredients you need to heal, and they are mostly done for severe dry eye patients, which not many options left, and reduce their signs and symptoms. They work very well. They're taken and they are processed to remove cells and the liquid we have, and they actually dispensed to them. Remember, these are of course preservative free, as a single dose saline, as a single dose serum to the eye, and patients can put their drops in the eye, and they are fantastic. They heal very, very quickly.
Okay. One question which has just popped up on my chat is, do you perform the MMP9 for all contact lens patients in your clinic? Is that something which you do routinely, and would you advise to do that?
At the moment, I think it depends if it's I think I don't. So first question answer is no, not all of them, but in a clinic, maybe contact lens wear or non-contact lens wear, if we suspect that this patient is towards aqueous deficient, and if this already we can see an inflammation in the eye, and it's a severe, moderate, or mild, and other battery of tests except MMP9 is confirming the direction of aqueous deficiency or evaporative dry, we may not perform it. But we like to perform for patients who have mild signs and symptoms, and we're not very sure it's aqueous deficient or evaporative or it's a mixed. In that case, MMP9 does well and tell us if it's a more undergoing mechanisms and processes going on than actually we see or we can measure by other tests. So in that case, if MMP9 is positive, we'll actually go more. We actually will go more with our MMP9 tests, and depends on the clinical research. So MMP9 test is something which will direct you where you can't guess it which direction is going.
Okay, and I think the same person is curious about the cost factor of the test. So is it really expensive? Do we get it handy? Of course, I think I'm not sure.
If UK, it's not very expensive. It's possible to do it. It depends on, I think, the supplier of your country. So okay. That's why, I mean, it's not as cheap as doing fluorescence staining. I would think it's just not as cheap. So, but what you can do and perform to anyone. But we do perform to many patients if we want to just to quantify how much inflammation going on the tear, and then it's kind of confirmation which direction the treatment is going. But we do it quite regularly for our studies. Like Rachel is doing one of her study here, and she's doing MMP9 for all the patients.
Okay, great. And any ideas on the role of supplements? Do you prescribe any additional supplements, and what is the choice if you would want to take about the supplements in dry eye disease practice? Do
you mean tear supplements or oral supplements?
Probably we'll talk about tear supplements and see if
Tear supplements are, again, it comes in two different forms. Essentially, it's aqueous form and a lipid based, and now we have more and more options nowadays as lipid based forms. It could be spray also, and at different concentrations and different brands, etc. Again, if it is aqueous deficient, we will like to go for more viscous and of course non-preservative ones. And if it's aqueous, if it's evaporative type, then we try to preserve the tear and reduce that tear breakup time. And as we go for more lipid-based sprays, there are multiple are available. And that's the first managements that we do, and most of the people around the world try to do it. So that's why it's so important to differentiate, if it is possible, between aqueous deficient and evaporative type. But most of the patients will be evaporative type, I believe.
Okay. And if we talk about nutritional supplements in terms of oral supplements or all of that, do you have any recommendations, or do you combine it with any other things in routine practice?
I think nutritional supplements are quite interesting area in dry eye disease, and I personally believe it does work. In addition to nutritional supplements, I think as a clinician, you need to really titrate the food habits, and that's where the history comes from, how the food habits are, and have more fruits and vegetables, etc. We know it's good for anyways. But also nutritional supplements include vitamins. Their role in tear and dry eye, I'm not very aware of how good it is, and at least I have no lot of evidence that I am aware of. The other thing is omega-3 supplements, and there are conflicting school of thoughts, and it may work, it may not work, but we know omega-3 is helpful for different other, it makes people more healthy, and I think it's a good supplement to start with and do management. So now oral supplements are easy to do and prescribe for us, but also a few other things that's as such, including supplements, when you're looking at, is the modification of workplace. It's a modification of sleep habits. And sleep habits are very important. Sleeping every day, same time, and having a long sleep as much as required, it gives eyes rest. And we know, and also avoid smoking. So these are things are really directly important for, and that's some modifications you can do, which often can even work better than just prescribing a supplements. But omega-3 is a good idea to start with, but we have conflicting school of thought that how it directly improved dry eye disease or not. I think some of the clear randomized clinical trials, at least from Melbourne, has showed it does work very well. But some of the studies from university, I think one or two, it shows it is not good. Depends what type of omega-3 it is. Actually, there are a few different types.
All right. So, I mean, it's safe to say that dry eye is a multifactorial disease. So it may require multi approach in terms of management as well. So it's not just prescribing the teardrops all the time, but additional, supplements, environmental modifications, as you mentioned, are really important.
Yep.
Yeah. And
supplements are good. And there's a couple of studies which I just supplements psychologically, patients feel better if you prescribe cycle. So, and that does reflect directly in reduction of symptoms. But my question is, if the studies didn't look at if they are continue to have reduced symptoms over 2-3 years, probably the patients were followed up only for 3 years. So there's another thing which actually psychological does it, but how much it really helped in terms of objective assessments like osmolarity, MMP9. These are the few standards. I think there are a few conflicting studies around the world.
Okay, great. And one last question before we wrap up for today is, what are your advices in terms of Sjogren's syndrome? Which method of treatment do you think in your experience is better? Is it more of autologous serum or amniotic membranes? Any thoughts about this?
This is a good question. Well, I think amniotic membrane works very well if the setup permits. Not many has this setup, first of all, to have, I mean, you need really tertiary hospital setup there, and it does fantastic well. It may be hindering a little bit of vision because there's a membrane there, whereas autologous serum does well. Again, you definitely need a quite tertiary setup to actually extract and prescribe and make the such serum in a small vials for you need those vials. I think when someone has Sjogren's syndrome with the moderate to severe cases, I think we should have all our treatment battery of treatments to go ahead together to actually start treatment. We do not have many Sjogren's syndrome patients at here though. Okay,
and just one question which popped up. I think this is a bit interesting, so I thought I'll just put it across to you. The biomarkers, some of the biomarkers test requires tear collection. So, in terms of patients who have reduced aqueous tear, is it difficult for us to collect tears, or do you think it's sufficient amount which we need is very minimum so that you can perform the test? Any thoughts about that?
That's a very good question, and we all struggle to collect tears from dry eye patients, to be fair, and often it's mixed, and we collect in a glass capillary tubes, but as I shown in my slides, depends on if you're using some commercial kits, they come with a small plastic or glass capillary tubes. It could be hard. And other thing with tears, just to go a little deep in research, if you go, the tears could be mostly a few types. The first is basal tears, which is normally we have without any intervention, etc., which is like in my eye and Prakriti's eye right now. But the other one is a reflex tears, which means if I'm sneezing or someone is crying, there's a reflex tears. Now, the qualitatively, they are very, very different. And the problem is when you try to collect tear, it's almost impossible not to reflex in the eye because you're touching small capillary tube in the eye and collecting tears. It's almost impossible, but trying to minimize that is the key. So coming back to answering your question is, yes, it is hard. We collect with the glass capillary tubes or the kit provider. The other way doing is to collect on Sherman strips. And that's some of the other studies are looking at in here. Rachel is also collecting tears on Sherman strips and then extract the tear from Sherman strip with the centrifuge. Centrifuge means spinning something very, very fast. It's like spinning something very fast. All the liquid will come out of the paper and you can still collect it. So you probably need to be research set up for Sherman strip. Yeah, and that's the only way to actually collect tears.
Yeah, I was thinking ask the patient to cry and collect the tears, but that's
then cry. Well, it will be for research or clinic. It will be unethical to make the patient cry for better treatment, and many will not understand. I think the alternative people has looked at it is to allow them to sneeze by tickling in the nose, and that also gives reflex tears. So, but then qualitatively they are very different, and that's why may not have good results when actually you're trying to guess what is in the tear normally and what is actually you're getting after reflex. The third one, as Prakriti mentioned here, is a flush tears, which does reasonably good job for research we do, and not for patients generally. Is that we dispense with a pipette around 20 or 40 microliter, depends which study we're looking at. And when you dispense a little bit of sterile like water, H2O, and then we put in eye and ask the patient to roll the eye right and left, and then collect the tears, which means basically which is cleaning and it takes all the debris and the proteins and everything, and we collect it, and it makes much easier for patients in dry eye, those who have tear deficiency or do not have a lot of tears. So we kind of collect all the proteins and everything, and we can still do reasonably very good job in terms of analyzing and see how they go.
All right, great. So I think with that, thank you so much, Dr. Dutta, for that wonderful, eye-opening presentation. I would say something which is biomarkers and which we don't really look at into clinical practice, but I think it's really important to come up to a better management plan if we know the background about the patients, what they are suffering from. So thank you so much for your talk.
Thank you so much. It was my pleasure to be here.
Yeah. The next session will be next weekend. Take care, be safe, and I hope to see you next weekend. Bye-bye.
Bye.
Bye. Thank you.